I have a question from Wanda. It says, is the activity in PET scans for cancer, does it always mean that cancer is present, can this mean something else? With PET scans, with a PET scan, patients are given a radioactive glucose solution. And if cancer is present, it typically takes up that radioactive glucose. Many times there can be also areas of pain or areas of inflammation that can light up on PET scans, or areas of residual disease. So if something lights up on a PET scan, that does not necessarily always mean cancer cells are present. Sometimes additional imaging might have to be looked into there. Another question from Wanda, she asked, what is your opinion on plant-based diets versus including organic or grass-fed meats, poultry, fish, products that contain lactate? What's best? And there are quite a few questions that came in regarding diet and what diet is best. And I think the best way to answer that is that all patients are individual. We have a different immune system, we have different metabolics, we have different ways of processing. In general, in my opinion, cancer does respond best to a low glycemic diet. And so I think across the board, that would be something that patients can implement. Low glycemic meaning low carbohydrate, low sugar, low in processed refined white flours and sugars. When it comes to choosing a particular diet for patients, there's so many options, right? We can have a ketogenic diet. We can have mixed and intermittent fasting or modified ketogenic diets, plant-based. Certain types of cancer can respond better to different diets. For example, there's a significant amount of studies with glioblastomas or brain cancers responding more favorably to a ketogenic diet. There are other types of cancers, when you look at the research, like leukemias and lymphomas, they tend to respond more favorably to a strict low carbohydrate diet. That could be something like a modified ketogenic or a full ketogenic diet. But again, when it comes to choosing a diet, we have to look at the metabolics of a patient. And sometimes you need to look into nutritional genome testing to look at the individual metabolics of each patient. There are certain genetic mutations where a patient may not be able to fully achieve ketosis because of their lipid metabolism. And so looking into that kind of testing can really help personalize a dietary regimen for a patient. Okay, I'm going to look at some of these live questions here. Just kind of dovetailing off of speaking about diets, there's a question here from Jennifer. Hi, Jennifer. Is keto or vegan diets best for stage 4 cancer? I will go off the limb here. I'm not crazy about vegan diets, especially for any type of hormonally driven cancers. I do think a ketogenic diet could be appropriate in certain situations like we were talking about with brain cancer, or for patients that have the appropriate guidance to follow a ketogenic diet. Why am I not a fan of vegan diets? Well, here we go. So when it comes to getting the right essential nutrients, especially proteins, and I know that this is a really iffy kind of contradictory topic to go into, but when it comes to getting the right essential proteins that someone needs, in order to achieve that with a vegan diet, you really have to consume a significant amount of combinations of those proteins, right? And that would include, a cup of rice and a cup of black beans. So yes, you can obtain all of the essential proteins and amino acids and nutrients that you need. However, that is increasing that glycemic and carbohydrate load. And so respectfully, I do prefer patients, especially that are dealing with more hormonally driven processes, especially if they're on a vegan diet and consuming more soy products, not ideal in those situations. Soy products typically are genetically modified. They also contain a lot of estrogenic properties and can perpetuate those processes and kind of add to proliferation in certain situations. So I hope that helps, Jennifer. Okay. I see a few patients or people commenting that the chat is disabled, but I'm still seeing a lot of questions coming through. So I'm sorry about that, but there.
Tell them to type in the Q&A instead of chat.
Okay, I'm being told that you have to type in the Q&A versus the chat, and hopefully that will help. And hi, Leanne, good to see you. Okay. Another question here, is fasting good before chemo? If so, how long should you fast? This is a great question. There's incredible research around fasting or modified fasting around chemotherapy, whether it's full dose or low dose chemotherapy. By fasting, it's really kind of taking away the fuel source for cancer cells. That's one thing. But it also allows for better penetrance of chemotherapy and mitigating the side effects of chemotherapy, again, whether that's full dose or low dose. What I have seen clinically, so there's a lot of ways to go about this. There's ways to utilize proton pump inhibitors. There's ways to use modified fasted diets where you do caloric restriction, working up to a full dose chemotherapy session. What I have clinically seen is that if patients fast even on the day of chemotherapy with water only, it really can significantly impact how they respond to that particular treatment. I think more commonly, we see patients fasting the day before, the day of, and the day after for optimal results. But again, that can be really challenging, especially if patients are dealing with low body weight or even getting the right nutrients in. And so minimally speaking, I find that fasting just the day of can be very supportive. Okay. I'm gonna go back and forth between the live questions and some of the ones that were sent in just to make sure we're answering everybody's questions here. I have a question from Donna. She says, what do you think about the use of fenben and ivermectin for treatment of cancer and helping with keeping metastasis at bay? Well, there's a lot of new research coming out about repurposed medications, and that's what these would really be classified as because they were originally created for different purposes. Ivermectin and fenbendazole are really anti-parasitic medications. But when you take a look at, and we could probably do an entire webinar on repurposed medications alone, but just to get to kind of the, to the nitty-gritty of it all, ivermectin is increasingly being studied for its use as an integrative and anti-cancer therapy. It's actually been shown in studies to inhibit cancer stem cells. So when it comes to your question, Donna, about keeping metastasis at bay, if we are inhibiting cancer stem cells, right, these are these kind of senescent daughter cells that are not a part of the primary tumor, but really waiting to be stimulated or triggered to spread into the system and latch on to another area for growth. So ivermectin has been shown to, again, inhibit cancer stem cells. It also inhibits angiogenesis. Angiogenesis is a process really called a new blood vessel growth. And it's a process that cancer cells and tumors use for their growth and proliferation. So kind of like cutting off their nutrient supply. So really effective there. Cancer is also a process of inflammation. We don't have to go deep into this, but ivermectin also has been used for other recent pandemic. And what it does is it inhibits some of these very inflammatory pathways. Cancer being an inflammatory process, we can see great benefit from that. So in my opinion, there's a significantly appropriate use for ivermectin as a repurposed medication. Febendazole, again, we could go into a whole webinar on this alone, but fenbendazole has a lot of research on it. It is originally wasn't meant for human consumption, but when you look at the research and there's actually very interesting studies comparing it to certain chemotherapeutics, but where I've seen a lot of the research on fenbendazole is actually overcoming drug resistance. So with certain types of cancer, colorectal cancer, we see this very commonly. Ovarian cancer, we see this very commonly, where patients develop chemo resistance. So they see initial profound treatment responses and reduction in tumor size, and all of a sudden the treatment stops working because the cells have become resistant to that particular chemotherapy. There are studies comparing fenbendazole to 5-FU or 5-fluorouracil, showing that in those patients that became chemo resistant, they were able to overcome that chemo resistance with the use of fenben even on its own. So Donna, I hope that helps. Again, we could talk about that for hours. And if you're familiar with my colleague, Dr. Nathan Goodyear, I know he's a big fan of ivermectin and really getting into the research of that. So there's definitely more to come on that. Stay tuned. Okay. So I'm going to kind of dovetail this into a few questions. There's a question about aromatase inhibitors. Does endogenous estrogen cause and or drive hormone-driven breast cancer? Nobody seems to want to answer this question, please. So does estrogen cause or drive hormonally driven breast cancers? Absolutely it does. So when it comes to breast cancer, we can have estrogen or progesterone receptor positive status, as well as HER2, which is a separate protein that has to do with more aggressive types of breast cancer. But endogenous estrogen, as well as exogenous, right, coming from an outside source, can absolutely drive the proliferation of breast cancer. So Susan, I'll have to look up and see where that specific question is about aromatase inhibitors, but what aromatase inhibitors do in the presence of hormone-positive breast cancer, especially estrogen-positive breast cancer, is it shuts down the conversion of testosterone to estrogen. And what that's really doing is significantly suppressing that hormone load. That being said, there can still be, what I think Susan is asking, endogenous estrogens circulating. And if those are, if the patient's terrain is not able to process those endogenous hormones, then yes, I would say that it can contribute to proliferation. And so aromatase inhibitors have a time and a place for patients, especially with hormonally positive breast cancers. I do think that they can be bolstered with other natural aromatase inhibiting activity. We have things like melatonin, grapeseed extract. There's a whole slew of natural forms of aromatase inhibitors that can really bolster that. But what it really comes down to is looking deeply into the metabolics and supporting patients' phase 1 and 2 liver detoxification of those endogenous hormones. Okay. This is a question from Jody. How do you know if you've become chemo resistant? It's a really great question, Jody. Well, I think the most obvious piece here is that if you've had a positive response initially to treatment and with the same therapies, and at some point are seeing progression of disease, right? At that point, there's likely mutations that have occurred within these cells and very likely have developed chemo resistance. We've talked about recently here fenbendazole being helpful there. We also see the use of high-dose IV vitamin C and really good research on this particular piece in helping to overcome that chemo resistance. Okay. There's another question here about nutrition, especially in the treatment of non-Hodgkin's lymphoma. This question's from Jen. And I do want to answer this question. I think it's really important. In particular, with lymphomas and non-Hodgkin's lymphomas, there's actually associations with celiac disease and non-celiac gluten sensitivity. You can take a deep dive into the research there. And so for any of our patients that have a non-Hodgkin's lymphoma diagnosis, I strongly encourage them to fully cut out gluten. And I know that makes me sound like a bad news bear there, but there are correlations with gluten, especially the inflammation that it can ensue, and not just cancer patients' bodies, but everyone's body. It actually upregulates certain inflammatory cytokines like interleukin-6, which drive these pathways of inflammation. And so more specifically for nutritionally speaking in non-Hodgkin's lymphoma, I would encourage patients to get a workup for celiac and non-celiac gluten sensitivity. But to be on the safe side, I usually pull that particular piece from those patients. I had mentioned just a few minutes ago that when we're non-Hodgkin's lymphoma and as well, all lymphomas really and leukemias do respond favorably based on the research to a very low glycemic diet. Okay. There's another question that came in prior to the live webinar today from Kathleen. Thoughts on how to starve cancer and the off-label drugs regimen. Really excellent question. A few ways to go about answering that. Repurposed medications, we've had a few conversations about here today. There's a significant amount of research showing the importance and the appropriate use of repurposed medications for different types of cancer. That being said, I do think it's important for patients to have an appropriate workup and evaluation with their provider. Even though these are repurposed medications, they should be used appropriately, right? Things like metformin can cause GI distress, right? But when it's used in the right space and in the right context and it's integrated appropriately, we can avoid those things. And so repurposed medications do have a significant use in different cancer types. There are some that are more appropriate for different types of cancer, but there is a significant use for that. Are there alternatives to hormone blockers and aromatase inhibitors? This question comes from Reem. We have touched on this just a little bit, and so yes, there are, but there's a caveat to that. Alternative treatments or natural therapies or natural aromatase inhibitors cannot supplant the impact of an aromatase inhibitor. Right. So, if a patient really needs to be placed on an aromatase inhibitor, that really should be done, with the guidance of a appropriate physician. We can make a big impact with natural aromatase inhibitors. But if we really need to have that suppression, they cannot supplant that piece. I mentioned melatonin. Melatonin has potent aromatase inhibiting properties. And so that's something we do use here in high doses as well as IV. It also has the benefit of having very profound anti-inflammatory and anti-cancer effects. This is a really good question from, I believe it's Christine. She says, is bone cancer reversible? So that's a layered question, and I think it's important to address. If a patient has developed bone metastasis or bone involvement, it really depends on the level of involvement that has taken place, how much osteolytic or sclerotic damage has taken place. And what that osteolytic just means kind of breakdown of bone. Sclerosis just means that bone has been broken down and now there's sort of this scar-like tissue in the bone. And so if those things have taken place, we might, depending on the extent of that, we might not be able to see that fully reverse. But if the bone metastasis is early, we have seen that resolve, especially on PET scans. And so one of the more profound therapies and an indication for this particular therapy would be bone metastasis, and that is hyperthermia. Hyperthermia is a natural form of immunotherapy using the infrared technology, where we can increase the core temperature of the body between 104 and 106 degrees Fahrenheit. By doing that, we are bringing all of these different immune cells to the area, to the tumor sites, right? That is creating a profound immune response. It's also allowing for permeability within those cancer cells, so it's allowing for better drug delivery. Bone is notoriously hard to penetrate for a good reason, right? It's the structure of our entire being, right? Aside from water, which our cells are made up of, but it's what all of our tissues are wrapped around, right? It shouldn't be easily penetrable, but hyperthermia allows for that improved penetrance of drug delivery, whether that's things like full dose chemo, low dose chemotherapy, high dose IV vitamin C, you name it. So I hope that helps, Christine, but yes, depending on the extent, bone or osseous metastasis or bone metastasis, depending on the extent, we can see reversibility. There's actually also quite interesting studies on melatonin aiding in the reversal of bone metastasis. Okay. Go back to some of these live questions here. Is there any research on chronic antivirals or for viral-induced cancer? Well, there is a lot of evidence. So, we know that this isn't new research, right? We understand that many pathogens, whether it's bacteria, whether it's viruses, whether it's yeast, Lyme disease, which is a bacterial spirochete, can influence the immune system and can contribute to cancer cell growth. And so speaking about antivirals, things like cervical cancer have an HPV related component. Certain lymphomas have an Epstein-Barr related component. Certain gliomas or glioblastomas can be associated with different antivirals. And so speaking to specific research on different types of cancers, that could take some time to go into. But as far as addressing viral load in these patients, I do think it's appropriate if there is a specific cancer type that is associated with a virus for there to be a proper workup there and then apply antivirals as appropriate. There is, what I will speak to here is methylene blue, and I do plan on doing a webinar in the near future here on methylene blue. It's a profound antiviral therapy, and a lot of emerging research on its influence on cancer and cancer cell proliferation. So if you stay tuned in the coming months here, I plan on doing a full webinar on that, but it's a natural antiviral that can have a profound effect on cancer cell proliferation, for sure. Okay. This is a question from Yvonne. Hi, Yvonne. How does hyperbaric oxygen treatment fit into treating cancer? This is a really good question. There, in the past, has been a lot of controversy on hyperbaric oxygen therapy and it being contraindicated in cancer treatment. Really, that is old research from the 1960s, really stating that oxygen could drive cancer cell proliferation. If we look at the new research, we actually see a significant benefit for hyperbaric oxygen therapy and oxygen therapies in general for cancer. Cancer, the environment in which it thrives is a hypoxic environment. And in general, cancer does not thrive in a low oxygen or a heated environment. So hyperbaric oxygen is flooding the tissue with 8 to 10 times the normal concentration of oxygen. And what that's really doing is, in a sense, kind of crowding out these cancer cells. So it can be useful not only to stimulate our healthy immune system and help with oxygenation of tissue, but it's kind of reversing this environment within the tumor microenvironment in the cancer cells. So it kind of pushes out the oxygen and kind of reverses that process and increases the, let me back up here. Cancer cells thrive in an oxygen-rich, low carbon dioxide environment. And that hyperbaric oxygen, when you're flooding that tissue, can switch that. So that gives us benefit not only to kind of crowd out those cancer cells, but it allows for improving the immune system and helping to really lay the groundwork for other therapies to come on board, because it's making those cancer cells vulnerable. So it's really an ideal therapy for many cancer types. Very few contraindications there, and so I think there's a great use for that. There is a question from BE. Hello, will there be an available recording of this session? There will be an available recording on this session on our YouTube channel. So stay tuned for that. It's typically uploaded in the next few days here. So it will be recorded. And I will talk about how to get the recording once we're finished with the webinar here. There's a question here from Randall speaking about melatonin. What is the dosage of melatonin? Good question. So when it comes to melatonin, especially in the research, you can surprisingly do quite high doses. It was previously thought that 20 milligrams was appropriate, and that's really where the research started. But what we're finding now is that we can do quite high doses of melatonin for patients. And so you can go upwards of 300 milligrams, but I really think that should be titrated with a practitioner and making sure that there's tolerance. I wouldn't just go taking 300 milligrams off the bat. We typically are weaning that into patients' treatment plans. A question from April here. Does low-dose naltrexone work synergistically with any other repurposed drugs? So low-dose naltrexone is an immune modulator, really a drug that has been used for time and time again at high doses to naltrexone, right, to help patients that are coming off of opioid narcotics to facilitate that detox process for them and help to wean off of those things. In the 80s, the name of the researcher is passing me right now, so forgive me, but in the 80s, it was really discovered that low-dose naltrexone, so at doses between 1.5 and 4.5 milligrams, we see this immune modulatory effect. Our immune system has different components, and we don't have to get into that, because if I do an immunology lesson, all your heads will be spinning and no one will be sitting here. But really what it's doing is balancing these inflammatory and anti-inflammatory components in the immune system. But specifically with cancer, it's actually upregulating CD8 cytotoxic cells. Cytotoxic really means a cell toxicity, right? So it's helping to induce toxicity within unhealthy cells. And there's actually a lot of research for, and I will get to your question here, April. I know I'm going on a little tangent. Low-dose naltrexone, if you look at the research, especially for patients that are quite advanced, maybe have a poor prognosis, there are studies showing increased overall survival and improved outcomes with the addition of low-dose naltrexone. There is research, interestingly, I'm not so familiar with it synergizing with specific repurposed medications, but there is research on low-dose naltrexone enhancing the effects when it's together with mistletoe, as well as high-dose IV vitamin C. Mistletoe is a natural form of immunotherapy as well, and so those do work very synergistically together. Okay. I have an attendee asking about black salve for breast tumors. Good question. It is not something I have used in patients. I know there is some, reported success out there. What I can say is that there are other things that can be used topically for breast tumors. Things like topical ozone, especially if there's dermal involvement, so meaning a lesion is protruding out of basically into the skin or outside of that tissue. Those are really called fungiating breast tumors. Things like topical ozone can be very helpful here. In the clinic here, we actually see the use of topical artesunate. And again, I would not recommend using that particularly on your own. That really should be used under the guidance of a provider. Artesunate is a very profound form of, it really comes from sweet wormwood, but artesunate can inhibit cancer cell proliferation, and we have seen that be very helpful in reducing breast lesions. There is some preliminary evidence, and I know I've seen anecdotally with patients, topical boswellia, which is frankincense. I have had patients in the past use that very successfully on swollen lymph nodes or palpable breast lesions that actually find boswellia as a COX-2 inhibitor. NSAIDs are COX-2 inhibitors, so non-steroidal anti-inflammatories. So it's actually very helpful if there is a breast lesion or lymph node that's swollen and painful, can help with reducing that inflammation in the area and reducing some of that pain. Okay. There's a question from an anonymous attendee, do you use ozone at your center? We do use ozone therapy as a quite profound form of anti-cancer therapy. Ozone, can be used in many different ways, both in IV, topically. It can be used in suppositories. You can ozonate olive oil, water, all of those things. But when it comes to cancer treatment, there are many different applications. And at our clinic, we do use ozone therapy. There are different levels of that, lower doses, and then there are higher doses of ozone that can be applied where we can, filter about 2 liters of blood. And so I'm getting a little bit ahead of myself. Let me explain that first. So an IV ozone treatment typically requires the starting of an IV, and we are then filtering the ozone into the blood and then back into the patient. What is that doing, right? Sounds like a pretty barbaric treatment. Ozone has the ability to donate electrons, and sometimes that can be a good thing and sometimes that can be a bad thing. In the case of cancer treatment, it's a good thing. When that extra oxygen pops off, it actually stimulates these chain reactions in the blood. And what that's doing is, well, first it has a very profound antimicrobial effect, but it also has the ability to inhibit cancer cell proliferation. And so when patients are dealing with a cancer diagnosis, we can't just treat cancer. And I know that sounds really wild because we, of course, want to have make progress there. But we also have to treat the terrain of the patient. And many patients are dealing with different pathogens, different illnesses. And so ozone's a really beautiful therapy that allows us to address many different issues with the patient. It's great for mold toxicity. It's great for viral load, right? And so mycotoxins, mold is, they are known carcinogens, right? And so we're actually killing two birds with one stone when it comes to therapies like oxygen. Our bodies thrive in a oxygen rich environment. Cancer cells don't, right? And so I think you can see kind of the benefit there by applying those different therapies. So yes, that is absolutely something that we do use here. We also use that in forms of insufflation or topical. I just mentioned that as far as addressing breast lesions. Ozone is also wonderful for any kind of wound healing. You can use insufflations both rectally or vaginally. They're a bit more gentle treatments, but when we're talking about things like cervical cancer that tend to have a HPV-associated component, ozone being antimicrobial, antiviral, can be administered very directly. So we get a more direct benefit in those cases. Okay. I'm going to take a quick sip of water. Let me do a time check. Okay. We can only go till 5:30, huh? I think we should have had like a 3-hour webinar. It's all right. Okay. Is there any way? Oh, great question, Wanda. Is there any way someone underweight could keep or gain weight while doing a low carbohydrate diet? Really good question. And I'll answer that in a few ways. I do think when patients are undergoing a very low carbohydrate diet, yes, weight loss is definitely a concern, especially for patients that are more slender, or even if they have a low appetite, not getting in a significant amount of calories. There are a few ways to keep on the weight there. Higher doses of omegas. I do actually prefer fish oils versus more plant-based, but those can be used as well. Those do help with muscle wasting and keeping up healthy acid levels of fatty acids. But you can use a higher calorie dense fats like coconut oil and avocados to get to kind of pack in those nutrients and to reduce that weight loss. Okay. Let's see. A question from April. There are several mistletoe varieties. Which one is the best for stage 4 rectal cancer? Really good question, April. You know, as far as there's a lot that has to be taken into consideration. I actually did a webinar on mistletoe a few months back that kind of goes into the detail about choosing what type of mistletoe is appropriate for each patient. In general, you know, their Viscum peony tends to do really well for different rectal cancers, but it really has to do with the constitution of that patient, the body habitus, their vitality. And so I really think an evaluation there and determining, you know, I've used Viscum molly, Viscum abietes in certain patients, as well as Abnoviscum fraxini. And so it really takes an evaluation to determine what's most appropriate there. I'm going to go back to some of the questions that were sent in before, just try to give everybody a fair shot here. There's a question from Albert, and I really wanted to address this. He said he was given Zantac, which is a proton pump inhibitor, 5 years ago, and he's noticed significant changes in his body and worried about it, understandably. I do want to address this. Proton pump inhibitors, so very commonly used, Prilosec, Zantac, omeprazole, used for reflux, heartburn. These drugs were actually developed to suppress stomach acid. And what they also suppress is the intake of specific nutrients. They can contribute to overgrowth of particular bugs like H. pylori. They reduce specific nutrients that can contribute to osteoporosis. And so unfortunately, when these drugs first came out, they were meant for short-term use. When patients are on them chronically or long-term, there is susceptibility for not only bone loss, but a lot of other health conditions. And the reason I'm bringing this up is because if you look at the research, long-term proton pump inhibitor use can contribute to be a contributing factor to developing gastric cancers or cancers in the gastrointestinal tract, but most specifically gastric cancer. So, Albert, I would suggest, working with a practitioner to help you wean off of that. In my clinical experience, with the use of those, a carbohydrate restrictive diet, many patients can actually get off of those proton pump inhibitors. High carbohydrate diets keep our lower esophageal sphincter open. And what that does is allows acid to pop up through there. The majority of patients that are on proton pump inhibitors typically actually need stomach acid. It's usually dietarily induced from what I have seen. So I hope you can find some support there, Albert, and I hope that helps. Okay. Another question from our kind of outside audience from Dan. Would you recommend for a person who underwent chemotherapy and radiation for throat cancer? Also, is it okay that I haven't gotten my taste back? I'm okay now, but haven't gotten my taste back. I see. Very common long-term side effect that can happen with radiation and chemotherapy, especially for head and neck cancers where they're doing radiation to the throat or the pharynx. And so not ideal, right? I would say the majority of us enjoy a good meal. If you have lost your taste from chemotherapy and radiation, there is hope there, that's for sure. It could spontaneously come back on its own, but if you look at the literature, zinc supplementation can actually greatly help in the return of taste and smell, especially if you've lost them from a cold as well. But in regards to this particular person's question, that can come back. There's a question here about peptides from Melissa. I would like to hear more about thymosin injections for immune function. Great question, Melissa. Peptides are emerging in the field of cancer care. And so there's different kinds, many generalized peptides. Peptides have kind of made their way into the anti-aging and performance enhancement movement. But when it comes to treating cancer, there are specific peptides like thymosin alpha-1, PNC27, that help to stimulate the immune system. Melissa's specifically asking about thymosin injections, really important. So if you don't know where your thymus gland is, it kind of sits right in the center of your chest here, but over time, it degrades. It's one of the only organs that we have that slowly degrades over time. And it's quite significantly involved in our immune function. And so by stimulating that particular component of the immune system helps to provide a more profound form of immunity. And so that's really the use of those peptides. Peptides are small amino acids that come together to form a protein. And proteins, when they fold upon themselves, and I'm going way back into biology here, so I'm probably losing a few people, but proteins really just tell our cells what to do. Lets us know if it's a hair cell, if it's a thymus cell, if it's a nail cell, right? And so when those cells slough off, they know how to regenerate. And so this is a way to re-stimulate an organ that over time degrades and that plays a critical role in our immune function and kind of tagging immune cells, so kind of, cancer cells. So stimulating the immune system to catch unhealthy cells and recognize them, right? Okay. Okay. My producer's over here sneezing, which is great. There's a question from Lisa. If your biopsy is benign, can you still have breast cancer? Also, should you take the tissue out in the surrounding biopsy areas? Really good question, Lisa. As far as biopsies go, medicine's not perfect. I know, I know it. But you know, if for some reason there is a lesion, whether that's in the breast, whether that's in the prostate, whether that's in the pancreas, and a core biopsy returns negative, I do think appropriate follow-up is necessary there. I don't think that tissue needs to immediately be taken out. You know, there's a lot involved in you know, making that decision or if it's appropriate for someone. But something that can be done if there is a questionable lesion, if on scans it looks suspicious but isn't really clear, to kind of avoid additional imaging. We're speaking about the breast, so I do think a 3D ultrasound could be really important here in assessing if there is vascularity in that particular lesion, as well as considering typically liquid biopsies would not be used as a screening tool. But if there is a suspicious lesion, I think a liquid biopsy could be appropriate. But more so looking for early cancer detection. There are, you know, there is new technology that is blood work that can be used to actually screen for early cancer detection. And I'm not going to speak specifically about those labs, but I would look into early cancer detection testing. That can be really helpful to determine if there really is something there that's malignant or concerning. Okay. Question from Susan. Ending my 10 years of letrozole. Chronic insomnia with high blood sugar that I cannot get down on a plant-based diet with no sugar added. Concerned as glucose could drive cancer. Is that correct? Well, yeah, Susan, unfortunately, there's plenty of evidence showing that glucose and things like insulin-like growth factor can absolutely cause cancer cell proliferation. Cancer is not just a product of inflammation or immune dysfunction, but about metabolics, right? And when we think about metabolics, it doesn't always have to do with fat metabolism, right? When we think about metabolism, we think of getting hot or cold or gaining weight or losing weight. Metabolically speaking, right, and especially when we're dealing with more hormonally driven or endocrine driven cancers, glucose can absolutely be a factor here. So in your particular situation, I think it would be appropriate to look at your insulin levels and your C-peptide levels and to kind of see what's happening there as well and get a more thorough workup. And also there's a lot of really great herbals or repurposed medications that can help support that particular process. But I think it sounds like you need a more thorough workup, looking not just at blood glucose, but more your insulin or your ketone levels, and just kind of seeing metabolically what's happening there. Okay. I know I missed some questions back up at the top, so give me a second. I just want to go up here. Let's see. Here's a question from Paul. Is there any chance of survival from stage 4 pancreatic cancer? It's a really deep question, Paul, and so I do have an answer for you. First of all, you know, here at Brio and myself philosophically, I believe the body can heal. I do believe that there's hope in that healing. Stage 4 pancreatic cancer does come with a quite, especially from the standard of care perspective, a grim prognosis. That being said, I have seen stage 4 pancreatic cancer patients thrive and do very, very well. There are so many variables in how patients respond to treatment, whether they've had full dose chemotherapy and radiation, whether they have kind of addressed the metabolics and the underlying root causes. Stage 4 is it's a number, right? And, you know, when we hear stage 4, we definitely think of advanced disease. But stage 4, you know, depending on the situation, can be very advanced or slightly advanced. And so really depending on each patient's situation, I do think that there is a potential for these patients to achieve no evidence of disease. I have seen it. I have seen patients with stage 4 pancreatic cancer also achieve a very stable status where they can live a very healthy life and a very profound quality of life with certain integrative therapies. So, you know, I do think that there are chances of survival from stage 4 pancreatic cancer despite its very grim statistical prognosis. Okay. A question from Kathy, and I think this is important to answer. What are your views on low-dose chemotherapy with or without insulin potentiation? Hot topic. So with low-dose chemotherapy or low-dose metronomic chemotherapy, the definition of low dose is really anything that is, any dose that is 25% or less than the standard of care. So if the standard of care is 100%, you reduce that dose by 25% or less. Previously, well, you know, I think there's still a lot of good evidence for insulin potentiation therapy. It's a little bit of a double-edged sword, though. With insulin potentiated low-dose chemotherapy, you are using insulin to sort of drive that chemotherapy deeper into the cells and by bringing those blood glucose levels down. The double-edged sword with that is that we spoke about this a few minutes ago. Cancer can use glucose and insulin-like growth factor as a proliferation factor. So we can see a very profound response to treatment, a very targeted form of chemotherapy. But also we have this ever so slight risk of potentially triggering cancer cell proliferation. If you look at the more current literature, we've moved our way, especially at the thinking at our clinic, to just low dose chemotherapy. And if you look at the literature, we can still see the same profound benefit without the use of that insulin potentiation. So I think there's benefit, especially to both. But if we want to use best practices, if we can avoid any potential for stimulating cancer cells, then we're going to do that. And so at our clinic, we only do low-dose metronomic chemotherapy here. Okay. Let me see. I think we have time for one or two more questions. This is a question from Victoria Lynn. My goddaughter has triple positive breast cancer. Since her cancer is estrogen related, her doctor does not want her to even take bioidentical estrogens. I would agree. What can she take to keep her heart, skin, and brain healthy like estrogen? She is postmenopausal. Thank you. Great question, and this is something that a lot of patients face. Obviously, with a triple positive breast cancer, that means estrogen, progesterone, and HER2 positive status. Those cancer cells utilize estrogen for proliferation. And so obviously when these patients are going on hormone blockers, whether that's things like a SERM, tamoxifen, or aromatase inhibitors like anastrozole or letrozole, it's suppressing all of that. For females, estrogen is very cardioprotective. It's protective to the bones, to neurological health. And so in those situations, I think it's really important for patients to get a thorough workup of their hormone metabolites and to really assess what areas need support. And so there are a lot of natural non-hormonal therapies that can be used, especially if patients are having symptoms. Things like black cohosh or vitamin E are very, very helpful here. But it is a fine line in stimulating hormone production. So in my experience with these situations, we are looking deeper into bone health, really prioritizing where they might symptomatically be having issues. So, you know, depending on their age, you know, we might need to do a workup for osteoporosis and be supportive with bone health. We might have to do some things that are more cardioprotective, things like CoQ10. and so I hope that helps, right? But in those situations, patients do need to have a thorough workup to kind of assess the integrity of those other systems just before kind of picking and choosing certain therapies to support the loss of those hormones. Okay. I know I wasn't able, I'm really happy to see the engagement here and the amount of questions that everyone has. And, you know, in the future here, we are going to be including more Q&A webinars like this. And so if I wasn't able to get to your question today, I hope to do so in the future. If you'd really like to receive more information about these webinars or notifications, you can subscribe to early for our next webinar or watch the replay of the past webinar by including this one. If you visit www.brio-medical or brio-medical.com/resources/webinars/ and that's where you can find all of our past webinars and sign up for the ones in the future here. If you'd like any additional information on any of these treatments that we've talked about today, you can visit our website at www.brio-medical.com. Feel free to follow me on Instagram at Dr. LaBant, and I'd be happy to engage with you there. So I really appreciate your time and attention. And again, if I wasn't able to get to your questions, I tried to lump in some similar questions and answer that together. So I look forward to seeing you all in the future, and I hope everyone has a great evening. Welcome to Brio-Medical, a holistic and integrative cancer center and immune recovery facility offering advanced, research-based integrative medical treatments for all types of cancer. We offer comprehensive, personalized treatment plans that target the specific needs of each patient, utilizing a combination of both conventional therapies and the latest in integrative treatment advancements from around the world. Our team of doctors and practitioners collaborate with each other to create a personalized care plan for each individual, focusing on the root cause rather than just treating the symptoms. Our holistic and patient-centered approach allows us to develop a doctor-patient relationship beyond disease. At Brio-Medical, we utilize evidence-based natural therapies, including nutrient and herbal medicine, intravenous and injection nutrient therapy, holistic nutrition, mind and body support, whole body hyperthermia, oxygen therapy, insulin-potentiated or low-dose chemotherapy, immunotherapies, and peptide therapy, among other therapies that aid in rebuilding the terrain of the body and support a healthy, functioning immune system. Hyperthermia is one of our pillars for treating cancer holistically. Hyperthermia is a form of immunotherapy through the use of heat to kill malignant cells through controlled thermal effects. Hyperthermia sessions also sensitize other therapies, both natural and conventional, while avoiding the destruction of healthy cells as well as boosting immune function. Another one of our therapies is hyperbaric oxygen therapy, also known as HBOT. HBOT is the use of oxygen under pressure to supersaturate the fluid portion of the blood, also known as the plasma, with oxygen. Doing so triggers many different immune and repair responses. The PEMF machine, or pulsed electromagnetic field therapy, helps with cellular exercise. When we exercise our bodies on a cellular level, this stimulates the cells to get rid of waste and to allow fresh nutrients and oxygen to enter our cells. This device is our Prism red light therapy. This full-body cold laser machine emits red light energy that is absorbed by our cells and increases the body's natural healing process, as well as repairing damaged or injured cells and reducing pain, swelling, and inflammation. In this room, patients exercise with an oxygen mask in order to oxygenate the patient's bloodstream. During exercise with oxygen therapy, also known as EWOT, we can deliver oxygen quickly to the capillaries in the bloodstream. At Brio-Medical, we use ozone in different ways. A session in our ozone sauna is a powerful addition to any healing or detoxification protocol, utilizing the largest organ of our body, the skin. The ozone sauna increases the elimination, detoxifying, and cleansing capacity of the skin by stimulation of the sweat glands, as well as increasing blood circulation. We integrate these therapies alongside low-dose chemotherapy and targeted therapies such as immunotherapy to optimize patient outcomes. This is our IPT suite. Another one of our pillars for treating cancer here at Brio-Medical is insulin potentiation therapy or low-dose metronomic chemotherapy. Low-dose chemotherapy allows us to target cancer cells while preserving immune function. At Brio-Medical, we believe a healthy immune system is the cornerstone of well-being and optimizing outcomes for patients. Our mission is to stimulate the innate capacity of the body to heal itself through our individualized, holistic, and integrative approach. Thank you so much for touring our facility today. For more information, visit our website and schedule a free consultation today.